Hello, how you doing?
Good, how are you?
Good. Thank you for presenting, by the way.
Oh, no problem. All right, let me go ahead and share my screen.
Yeah. We usually give everyone to like 105. That
Okay,
way most people show up, and then you can share your screen there. Okay. Yeah, but
sounds good.
just a couple of minutes of silence here while everyone gets joined in.
Let's see, it's saying sharing has failed. Let me try this.
Oh, there you go.
Is it, let me see. Is it just the PowerPoint?
Yep.
Let me see. Yeah, there it goes. All right, yep, whenever people are ready.
Yep. How long have you been in Norton's?
I have been there since July. I was in Miami. I did my residency fellowship, worked a little bit, and then decided I wanted to do an ultrasound fellowship after being an attending, and I went to Denver, and then I came back over here.
Oh, okay. Oh,
Yep,
great. Awesome.
cool.
So we have your colleague presenting next week too. So
Yeah,
maybe.
yeah,
Um,
Beck
what,
is.
what's your volume like in the hospital?
So pre-COVID, so we have a satellite in the main campus. The main campus usually has about 60,000 a year.
Okay.
And then the satellite that we cover, I think, has about 20, but now it's much lower, though our numbers are kind of get back up to the normal springtime for pre-COVID numbers, which
Yeah, same here. So it looks similar to us at Connecticut Jones. We have like 60, but our numbers are starting to, our numbers in acuity is starting to go up. So it's been a busy like month so far.
yeah, it's adjusting back to getting back into shape and seeing a bunch of patients.
Yeah, yeah, that's what we were all saying because the other day we're like we have this surge mode where we like announce to the hospital that we're in surging, like we have a certain criteria, and then but then we look at the numbers and it's like this is we should be able to handle this, but we're
Yeah,
not out of shape. So
it'll come back.
yeah, they'll come back.
And at least it's coming back during the spring and summer instead of
That's
the
true.
middle of winter.
So yeah, but it should be interesting next few weeks and see how everything goes.
Yeah.
All right. Good afternoon, everyone. Thanks for joining again this week. Today we have Paul from Norton's Children's Hospital who presented some cases. So thanks, everyone. And Paul, you can take it away. And thanks for presenting.
Oh, definitely. So I'm Paul. I'm coming to you from Louisville, Kentucky, and I'll be doing some interesting cases. Is the screen okay?
Yep.
Okay. All right. So the first case is from our friend, the Bounce House. So I had an 8-year-old female that came in with chest pain after being in a bounce house a couple days prior. She said that when she fell, she kind of fell on her shoulders and it hyperflexed her chest. When she first came in, she had a chest x-ray that, of course, didn't show anything. But one of my residents wanted to take a closer look with the ultrasound. So we took a look and we found this buccal fracture in the sternum. And here's it in the long axis and then in short axis, and then a couple of videos of it. And so this is kind of a plug also for the POCUS Atlas, which I submitted this image to, which is a great resource for those of you who aren't familiar with it. You can post images as well as use it for your lectures. So sternal fractures are actually relatively rare in children. We most of the time think of them as in high impact motor vehicle accidents, but they can be from hyperflexion injuries that are often missed by x-rays and even CTs. There's not actually been a comparison in CT versus ultrasound, but when you look at it versus a plain x-ray, the ultrasound's more sensitive and more specific for these fractures. Any questions on that first case? All right, so I'll move on to the second. So even though I'm coming to you from Louisville, I'm from West Virginia, and I'm a big West Virginia football fan. So this second case is a football player, high school football player, that said he was at practice. He started to run, and then started having pain in his left ankle. He said that he was having an inability to bear weight. And when he first came in, he was initially seen by a nurse practitioner who got an x-ray. The x-ray was negative, but she told me that when she squeezed his calf, there wasn't any plantar flexion, and she was concerned for an Achilles tear. So I did the ultrasound, and when I do these ultrasounds, I usually start in short axis and I'll find the calcaneus, and then I'll move into long axis, and then I'll look at the injury itself. So this is the injury, and it's a near complete tear. You see at the very bottom, there is still some attachment of the ligament, but a pretty significant hematoma, and the ligament itself is partially torn. And here's another image of it. And here is third video before I show you his normal. So this is what the normal Achilles looks like, and it's nice and linear. And whenever I look at ortho or sports injuries, I like to look at the normal and the normal when I'm comparing them, just to see that if there's any small tears, if there's any blood or anything, it helps demonstrate what normal versus abnormal is. And that's the nice thing about orthopedics, is most of the time you have two sides to compare to. So Achilles has been reported in adults, ultrasounds, not a whole lot in pediatrics. And what they found was that in your H&P misses about 20 to 30% of these ruptures. There was a study that Hartgerink et al. Did that compared ultrasound done by radiology to the surgical report, and found that the ultrasound was actually 92% accurate when comparing it partial versus full tears to what they found when they took them to the OR. So my young man that had this tear was actually followed up with orthopedics. They confirmed that it was a partial tear and had a consultative ultrasound, and they took him to the OR to repair it.
Paul, in what position do you have the patient when you're doing this exam?
So for this one, I usually have them lay on their belly if they can do it. That way I can have both the Achilles available so I can compare them side by side. And we've actually had a couple of them recently here at Norton, and it's more satisfying, I think, for the patient when you show them what's going on, as opposed to waiting for orthopedics to get their MRI, or if the radiology tech's comfortable, sometimes they'll do the ultrasounds with them. But I was with the ones I've had recently, I show the parents and they're able to see exactly what it is. And then we put them in a splint and have them follow up.
Did you get a confirmatory ultrasound or MRI, or just on your POCUS?
We got a confirmation for this one. And we can get MRIs occasionally, but they usually don't like us to use it for ortho injuries. But it's a quick way to look, and it's once you've done a couple, it's a pretty easy scan to see. And like I said, when you compare it to the other side, it looks clearly torn. Any other questions on this one? All right. So I'm kind of doing an orthopedic theme, and I'll be doing some procedures as well with it. So this is a 21-month-old male that came in because he was having some swelling to his right knee. He was having a little bit of trouble with his gait, as well as when he had a recent viral illness, a URI. He was first seen at our satellite ER, where they found that he was febrile to 101, that he had a heart rate of 162. The physical that they had was that he was having trouble flexing his knee and that his knee was red and warm. They initially did some basic labs that had an ESR of 30, a CRP was 15, and sent him to our main campus after they gave him a dose of clindamycin. When he got to us, he was his vitals had normalized after he got some antipyretics. We repeated his labs, and his white count was 10, and his ESR was 49. They also did plain film at our satellite, which was normal, no fractures or anything. They saw a little bit of an effusion. So what we did is we got some ultrasounds of his knees. And when I do knee ultrasounds, what I'll usually do is I will image the knee in short axis so that I can find the femur. And then I turn it into long axis and I go towards the patella. And this is the image in long axis going towards the patella, with the patella would be on the left hand of your screen. And just kind of fanning through it. So let me see. One of the things about doing this procedure is that, is that sometimes when I do the procedure, I do it in long axis, and I usually find the biggest pocket, depending if it's on the right side or the left side of the patella. And once I found that, I go in on that side. So there was a study that showed that the success rate between doing it by landmarks versus with ultrasound is about the same, but it's less painful and you get more fluid. And as you can see in the first attempt that was done, they overshot the fluid. So once we pulled back a little bit, we were able to get into the joint space and get a good amount of purulent fluid. The white count came back as 145,000, which anything over 50,000 is consistent with a septic joint. He was then admitted, and then orthopedics took him to the operating room and cleaned out his joint. And just kind of the point on this one is that Weiler et al. Showed that it's less painful. Patients think it's less painful, and you're able to get a little bit more fluid when you use the ultrasound, even though the success rate really isn't much different. And as you saw, we overshot and then we came back and we were able to get the fluid much easier because we saw where our needle was.
I'm assuming you sedated the patient, right?
We actually just did a little bit of Versed, and when we did the procedure, we used the J-tip. I don't know if you have J-tips.
No, we don't.
So it's pressurized lidocaine. So you can use it to numb up the skin without a needle. And then when you go with your needle, they may feel a little bit of pressure, but they shouldn't feel the pain from the needle going in. And then as we go in, we inject a little bit of lidocaine before doing the aspiration.
Paul, this is Lay from Yale, Connecticut. Can you just look at those clips again? His knee joint looks funky to me. I'm not sure what all those densities are.
Okay.
Which bone are we looking at?
So we are coming in over the femur.
So the bone that in picture is the tibia, proximal tibia.
Yeah.
Yeah, that joint just looks funky. I mean, it doesn't look like normal. Obviously, not normal joint fluid. Yeah.
Yeah.
Yeah. Okay.
Yeah. So there's probably a little bit of breakdown of the bone as well. Let me go back to the video. Yeah.
That's nice.
And things come in bunches. And I've actually had 3 kids that I've tapped recently. And it really makes it so much easier when you're using the ultrasound and when you're doing it with a resident or fellow that they can see where they're going. Because where the pocket is doesn't necessarily, I mean, a lot of times it's just big, but for the smaller pockets, or if you're doing it on a smaller child, it's just easier to go in and remove it that way. All right. Any other questions about the knee aspirate? Okay. So I am going to continue with our orthopedics theme. And sorry, let me go back. This is a 12-year-old male who was playing basketball with one of his siblings. He got pushed and he had a foosh injury and was found to have a deformity of his forearm. This was seen at our satellite. So some of these are seen at our satellite, and everything's protocolized. He got opioids, oral opioids in triage, as well as they got an x-ray that showed his fracture that was displaced. And this is what it looked like on ultrasound. So sometimes we're able to do sedations and reductions at our satellite, but it was a particularly busy night. It was, I think, a Friday night. And for most of our reductions, if we send them downtown so the orthopedics can do them, but we do some of them ourselves. And we can occasionally get sedation done at our satellite, but if it's busy, we can't. And I gave the mom and the child an option of, we can't sedate to do your reduction here, but I can do a hematoma block if you'd like, and then we can reduce it that way. And the mother and the child both opted to doing the reduction after the hematoma block. And prior to my ultrasound training, I did a lot of these blind, but again, it's just easier when you see where you're going so that it's less painful and you can get into the joint space a little quicker when you use the ultrasound. And I do this in plane when I do it. And so here you see the needle coming in from the left hand side of the screen and getting into the joint. And you can see it a little bit better on this one. And here's your needle right here. And you can actually see some of the lidocaine going into the joint itself. So I was able to block it. I walked away for about 10 minutes and then I reduced it. He seemed pretty comfortable for the reduction, but unlike a sedation, they do feel that crunch and it can be a little bit shocking. So it's usually teenagers that I'll try these on because the smaller kids don't want you getting near their forearms with that needle, first of all, and the reduction itself can be a little bit traumatic. So kind of a summary slide on this one is Bear et al. Showed that hematoma blocks can be as effective as procedural sedation for reductions, and they reduce the length of stay in the emergency room, which when it's busy is always important, as well as if you're at a satellite, you may not have full access to sedation. It's a great way of doing it. Any questions on this one?
No, Paul, if you don't mind, I was going to ask the group and see if they use hematoma blocks. Is like in my shop, it's pretty much everyone gets ketamine. So I was wondering what other people were doing.
It's Erica. I did a study as a fellow looking at hematoma blocks as an adjunct to ketamine sedation to see if you did both, if it would be any better. And our conclusion was it was an underpowered study, but we found no difference in the two. I find it really hard to convince parents to do hematoma block alone if ketamine is just so good and so safe, it works so well, that it's really hard at our shop to do anything but, unless it's like, what ortho comes in and says it's just a little push, then maybe we'll get them to be able to do that.
Hey, Erica, I remember that study, but I also hate every time ortho comes in and says, oh, it's just going to be a little push, because then it's a little push and then it's a little molding and then some more molding.
Agreed. Yes.
Like, oh,
agreed.
I saw someone put in the chat about a hematoma block with nitrous oxide. I was planning to do this. We were about to buy a nitrous oxide thing when COVID hit, and then they told us, no, we can't have it. Is anyone doing that and now, and do you like that?
We put a nitrous system in down here in Charleston probably 3 years ago, like a portable system. It ends up being obnoxious for us because state logistically, it has to be MD administered. So like there's technically the attending has to be the one holding the mask on the kid's face, which means you up the ante on the number of bodies needed, which is funny because like the dental school is like willy-nilly, all kinds of mixing meds, including it. We've done a few hematoma, and like it worked fairly well for like a digital block for kids who weren't going to hold still for it. I personally found very few cases where just like PO benzo and a little more aggressive holding didn't accomplish the same thing without needing to, have now 2 physicians administer stuff.
We did semi-routinely use them in Miami for when ortho wanted to just to push and they were kind of in a hurry for older kids. But yeah, we didn't use nitrous. And then here in Louisville, it's mostly, I feel like, at the satellite that we do this.
Yeah. Ours routinely balk at it, unless it's like a really older kid. And even then it's usually an arm twist to them. And they'll argue that they can't reliably get into the hematoma, or, it's usually 2 bones. So they argue it's 2 injections and, versus 1 IV and out.
Yeah. But I feel like with the right patient and it really has to be just a quick push that it works pretty well.
Thanks for the discussion, everyone. Yeah, that was yeah, it's interesting. So yeah, sorry, Paul, that I interrupted that, but I just wanted to see what people were doing.
Yeah, definitely. Yeah, and if you guys have any other questions, feel free. All right, so the next case is a little bit different, but kind of on the same topic. Is a 16-year-old male who presented to an urgent care nearby with chest pain and difficulty breathing. That started earlier that day. Said the pain was substernal and was mostly in his left upper chest. That hurt more when he breathed. Said that it was no history of smoking, no history of asthma, no history of trauma. So they got an X-ray at the urgent care that showed an apical pneumothorax. And we confirmed the ultrasound, the pneumothorax with our ultrasound. And as you can see on the left-hand side of the screen, there's no movement, where on the right there is. And this young man was statting 100%. He was slightly tachycardic, but he was stable otherwise. And here it is on M mode. And you can see the sandy beach next to the barcode, which I know is a little bit controversial to use M mode, but it's cool to see it side by side. So the reason I brought this one up is that I did a serratus anterior block on him before I put the pigtail in. And what you can see here is ribs, the lung down here, and then you have his serratus muscle with the lat over here. And you can see his the needle coming in from the left-hand side of the screen, and there's the needle right here. So not ortho, but kind of on the procedural block side of thing. And that's and then here it is with the sedative, the anesthetic in. And with him, I gave him a little bit of benzos before. I used the J-tip to numb up the area. And then I did the procedure, and he actually got his chest tube, got it removed, was discharged, was seen at another outside facility where they noted that his pneumothorax reoccurred. And then they did conscious sedation, and he was much happier that we blocked him as opposed to the conscious sedation at the outside facility. And I'm going to talk a little bit about this block because I feel like it's not as commonly used in pediatrics as it is in adults, where they use it for rib fractures. They'll use it for abscesses. They may use it for zoster as well. And it's actually a decently simple block. The complication for it is that you could cause a pneumothorax, but when you already have a pneumothorax, it's fairly safe. So I'm going to use some of the images from Highlands Emergency, which does a pretty good job of putting out information on their blocks. So it is a plain block, so you're not looking for a specific nerve. And I usually go at T4, T5, and it will take care of T2 all the way to T9. So it's good for anything on the side. You do have to use a higher volume for it. So even if your ropivacaine is less, if they've maxed out on the dose, you still need about 20 to 30 ml. So you need to dilute it out with saline, just like you would for a fasciolaca block. So the nerves you're looking that you will be getting is the intercostals, which is good again for putting in a chest tube if they have a fracture, if they have any skin findings. So when you go in, you usually go through the lat, the serratus, and then you can go right above the rib. I'll show you another approach. You can either go above or below the serratus. It's just that I feel like it's easier to go straight for the bone because then you have an end point. you can also come in from the posterior. And this is how you would come in posteriorly, and you would inject in between, the way they showed it was in between the serratus and the lat. And it actually works pretty well from what I've seen. And I just put a pigtail in. Any questions on this one?
It wouldn't surprise me if you're the only person doing this in pediatrics. I don't know. It's pretty cool.
Yeah.
Do you have colleagues at Louisville? Like, is this a somewhat regular practice or?
No, I'm the only one I think doing it here. I picked up some of these tricks from doing my fellowship at Denver Health, because even though it's a PEDS ultrasound fellowship, we kind of do things with the adult people, and our lecture was with the adult people. And when we go and do some of our scannings, it was with the adult fellows as well. And they were very comfortable with this one and use it semi-regularly. And since it's a plain block, it seems like it's more difficult than it actually is. And if you're doing it for a pneumothorax, it's actually, I mean, you've taken away the risk, because you're going to put a needle into their chest anyway.
Yeah, it's very cool.
Yeah.
I tried it once in a kid that had uncontrollable pain from an unknown cause of like his entire like back and lateral ribs. And I had a really hard time getting it into the right plane so that the lidocaine would actually spread like it was supposed to.
Mm-hmm.
The other problem we ran into is that you have to use large volumes, right? So you have to calculate the maximum dose for the kid's weight, and that may not be enough to like get adequate spread. And so, sorry about the dog in the background. And so we had to have intralipid available. Then the nurses made a big deal of it over the intralipid, and they had to figure out how to use it. We had to get it from pharmacy, all that stuff. So it was kind of a bit of a hassle, but I'm not above trying it for like a chest tube. But again, ketamine works really well and is less of a hassle for us. So I don't know what other people think.
Yeah, you do have to dilute it with saline to get the volume, because you need 20 to 30, and it makes a pretty good bubble. And I did give him some time before I actually put the chest tube in, because he was pretty stable. We do have a pathway that for all of our fasciolae blocks that we have interlipid available for when we do any sort of proximal blocks. So it was initially started for our fasciolae, which we talked about at P2 a couple days ago. And the nurses are pretty comfortable. And the way we have it set up for the fasciolae is they set up our tubing and they push in the anesthetic as we guide it in with our needle, and then we have the interlipid available. So I think because we have that protocol in place, it was a little easier to do this one.
And are you using lidocaine or ropivacaine?
Ropivacaine, because or bupivacaine, we use I'm trying to think, because Denver and here are different. You can either use ropivacaine or bupivacaine, whichever your institution wants. And it also is nice because it gives them a little bit of extended pain relief from having the chest tube in place. It does not help with the expansion pain, and this patient had some pain when his lung re-expanded. So I gave him some Toradol, and between the Toradol and the block, his chest wall felt a lot better, as well as the lung from the expansion.
Why did he think that the block was better than the sedation, out of curiosity? Like, what was he reporting to you?
He just didn't like how it made him feel when he was sedated, and it was the long-term pain management that helped with that he liked.
Got it.
Because they'll get 6 hours or so of pain relief from the block if you're using a longer acting. And it did, like I said, it helped so much that Fred had already established the fascia iliaca block, because the nurses felt really comfortable. They pulled everything up and helped me with it.
Paul, to Erica's point, I was thinking about this the other day when, we were talking about the other blocks. Is there ever a circumstance where you're using lidocaine over one of the more long acting? Like, I was thinking about it, and I don't know that there's really a circumstance where I would choose to do that. I don't think.
If I'm doing something for a quick procedure, I will. So say I'm doing a posterior tib for a foreign body, I'll use Lido. Or if I'm using it for hematoma blocks, I've been using it, but I know that you can use a longer acting one, because usually once you get that bone back in place, they're a lot more
You're all set.
comfortable. Yeah.
Zach, from our perspective, as we do our, I'm largely grouped with adult folks who do a lot of these, are two big considerations. So we'll do Lido always with brachial plexus, which is especially if you're doing interscaling, with the assumption that you're just going to drop the diaphragm, and so you're going to recover it faster.
Yeah.
And then also thinking of like how high are you going, and how much actual motor function are you going to get taken out, and are you willing to tolerate? Insensate limb is one thing, non-functional limb is another. A lot of times you're doing core stuff. Broken femur, ain't nobody walking on it, so it doesn't really matter.
I don't mess around with the brachial plexus, at least not yet. But yeah, it's a good point.
And I can't remember the name of it, but there's another block that the adult people are starting to use more for the fascia iliacas, because they want to preserve that motor function for, even though no one's going to be on it. But yeah, the kids, we don't need to worry about them moving their leg after. Are you doing mini brachial plexus in South Carolina?
Our adult group, our peds group doesn't.
Okay.
The adult guys do for, variety of stuff. They'll do interscaling for shoulders. It's probably the more common one they do. They'll do, some of our hooks will do slide down a bit and do like a ductor canal for your femoral, which gives you a little less of the upper motor. And then they'll do a lot of, they've started doing some of the ping block.
Yeah, the ping, that's the one I was thinking of.
For the hip, and that gives you truer hip capsule for like the more proximal, like femoral neck stuff, and old people, fossil fall stuff.
Yeah, I like using blocks. I feel like it's probably one of the things that we can start to be using more in peds, but you do meet resistance. But Fred and Becca here have had fascia iliacas ultrasound guided, and that's kind of how they converted the group to ultrasound, is that they started doing those, and Ortho loved it. And we have attendings that graduated a long time ago, and this was their introduction to ultrasound. I have heard adult providers say that they feel like the serratus block is kind of on that same level as a fascia iliaca because it's a plain block. And for us in peds, we're primarily just using it for pneumothoraces, and it works pretty well with low risk. You just have to get that volume in, and they have to be a stable patient.
Paul, that's a really interesting point. I never thought of, some of these more simple blocks as like the entry point for like more veteran PEM attendings. Because, you do have to kind of pique their interest and grab hold of them for them to kind of have enough interest to pursue it. I know, Erica had her curriculum and had some success there, but, that's kind of a universal, obstacle we all face, but, coming at it from that angle is an interesting perspective.
Yeah, and it's instant gratification that you get with these blocks. And I know a lot of people were doing the fascia iliacas blind, where they fill for the 2 pops prior to using ultrasound. And when you use ultrasound, particularly for fascia iliaca, then you take away the possibility of going into the vasculature. And it really works so well with these kids that have femur fractures.
I'll say one plug for, this is obviously getting things going. Depending on your relationship with your anesthesia department, I did a month with our regional anesthesia team to just get more play with these. And then they obviously do a far more expansive set of stuff, but then they're just like cranking and it's like, 6-8 blocks in a morning pre-op. And if your relationship's good, then you may be able to get in there and do some and then pick up some of it because they really translate well. I mean, like this is the same, serratus is basically the same thing, slide down and you've got a tap and you can knock out, your lower abdomen as well. And so you can take out pretty much the bulk of the core with the exact same, effective muscle plane.
Are you using tap at all?
I had a kid that was going to do it on, and then we didn't have interlepid, so I didn't.
Okay.
Had a nice big abscess in her superficial right lower quadrant.
Yeah, I know the adults are starting to use them for their appies to keep them off opiates overnight before the surgeons take them in the morning. But I feel like our peds surgeons or peds surgeons in general like to have their physical exam of. Cool. So that was my last case. And here's some of my references. But I enjoy ortho and I enjoy blocks. So I think it's one of the things that we can definitely take advantage of in pediatrics.
Yeah, thank you, Paul. That was very helpful and very interesting. So definitely, I'm going to look into your the resources you said. But yeah, because I don't think I do as much blocks as I should be doing. But yeah, so thank you for the cases.
Yeah, definitely. And if you need our protocol for our fascia iliaca, just let one of the three of us know, because they have it so standardized that when I said that I was going to do these blocks, and I've done it a couple times, the fascia iliaca or the serratus blocks, that they didn't even balk at me. They just were like, okay. And they set up, I just set up like a fascia iliaca and they set up.
Yeah, great. Yeah, I'll let you know. Thank you. Yeah, and then in the chat they're saying that there more people want to do more blocks now. So thank you for presenting.
Oh, no problem.
Henry, you got to have me down to talk to the group.
Yeah.
Spread the gospel.
Yep. Like I said, I don't think I do as many as I should be doing, especially after the conference we're having. I feel like I need to do a lot more blocks than I am doing right now.
Yeah, great job putting the fascia iliacus to the paper together, Zach. It's cool to see how other institutions are doing it. And it was kind of cool that I didn't know, but the Denver people joined and I joined, and that's where I had come from last year.
It's very incestuous.
It is.
Well, because your fellow's going to Sick Kids, which
yeah,
and there's like a little East Coast group, and it's kind of funny.
It is. And everybody knows everybody. Yeah, I'm starting to find out now that, because you're a year out also, aren't you?
Yeah, I think me and Matt are just now a year out of fellowship.
Yeah.
Is that right, Matt? Are we the same year?
I think so.
And also Julie. So
Julie's actually 2 years out. I was after her, but she did
Julie Leviter?
No, Julia Brandt, because she did her from Denver.
No, well, there's also Julia at Yale.
Yeah.
Who is our year also. So
yeah.
Anyway. Good times.
Definitely. And it'll be good to see everybody once we can start meeting again.
I know. Well, I feel like I know Matt and I've never been within 1,000 miles of him. So
yeah.
That's true, Zach. That's true. I feel
you know what I mean? It's like, yeah, it'll be cool. It'll be great.
Thank you again, Paul. And and thank you everyone for coming. And I'll hopefully see everyone next week. And thanks again, Paul.
Before people sign off, if anybody is interested, we have our last lecture for our administrative block at the fellowship at Cohen's. It is looking at credentialing pathways for fellows who have interest in that aspect of program administration, you're welcome to join us. We'll put the Zoom link in the chat in a few seconds.
Cool. Awesome. Thanks, Matt.
Sorry, one sec. We're just having a freeze of our email system for some reason. $320. We'll put it in, we'll type it out at once as well. It's 320-216-6383. And the password is 1234. We finally got our email to work, so we're sending it to you. We'll be meeting in about 15 minutes. See you then.